Now, moving on to our third section, that we will be discussing what are the other carpal bones which can be fractured as well, and we will briefly going through the mechanism of injuries as well. We'll be going through the other bones such as triquetrum and Hammad fractures, the trapezium and capitate fractures, and the leonid fractures. Although they're very rare, but they do occur uncommonly as well. Now, fractures of other carpal bones, first and foremost, include the triquetrum. This usually results in avulsion of the dorsal ligaments as well, and it's not uncommon. Analgesics are normally used initially with the splintage is done for the wrist for few weeks, and occasionally it's almost 6 to 8 weeks. If the body is fractured, then usually heals after 4 to 6 weeks in plaster. Displaced fracture may need fixation, but then it could be in form of percutaneous fixation in form of K-wires, or later on we can do open reduction tunnel fixation with the help of a screw fixation as well. Now coming to the Hammad fracture. Hammad bone usually fractures in such a way that, especially when the person is playing a golf, for example, a fracture of the hook of Hammad follows a direct blow to the palm of the hand. The most commonly, it results in the pain around the base of the hypothenar area. This is what happens, especially in the golfers when they're using a tee to just to deliver it out. What happens is, if for some reason the stick gets caught in the ground, this can result in all the energy is actually transferred towards the wrist joint, and this can result in the hook of Hammad fracture. Fractures usually not seen on normal axis, on the regular axis, that is the PU view with the ulnar deviation, lateral view, and always on the supination or pronation oblique views as well. Why? Because you need a very special view. If you have a history and examination is such that you are suspecting hook of Hammad fracture, then there is called as carpal view, or carpal bones view is especially done to check for the hook of Hammad fracture. Or you may require simply CT or MRI to just check for what are the other bones which have got injured and what are the ligaments which have got disrupted as well. Usually the symptoms should result in a maybe prolonged, may need a fragment excision as well. Initially they sometimes can be missed as well, and later on they may present with AVN of the hook of Hammad and probably continuous pain over the palmar side of the wrist joint. Now coming to the displaced fractures which may need fixation, and this is usually the mechanism when the golfer is actually trying to hit a shot. That is where the maximum force gets transferred over the hook, and that is results in the hook of the Hammad fracture or the body of the Hammad fracture as well. Usually the most common among the body is the fractures of the distal dorsal lip associated with carpometacarpal dislocations as well. And there may be associated fractures of the body which are very rare, but that can happen as well, which is very difficult to especially define on the plain x-rays. Now coming to the trapezium. For body of the trapezium can be fractured if the shaft of the first metacarpal impacts on it. Now, as you know, there are two bones, the scaphoid, leonate, triquetrum, and pisiform from the proximal bone. But the trapezium and trapezoid are actually forming the second arch of the carpal bones. And that is when this body, the first metacarpal actually strikes it due to the thumb. This causes the fractures of the trapezium. But most commonly, they are not reduced easily, and they have to go for open reduction and tunnel fixation, which could be in form of K-wires, could be in form of screws as well. Then is the usually ridge of the trapezium may get fractured as well, but that can happen with a direct blow only, and usually seen on the CT or the carpal tunnel view, especially when we are looking for the hook of the Hammad fracture. This can happen if this is an undisplaced fracture, and this usually settles down with the cast for 4 weeks. The next bone after the trapezium and trapezoid comes the basically capitate. It's also the bone which is in lines in the second row, and usually it's lying in the center of the wrist joint. It's relatively protected within the carpus, but usually damaged only when there is a severe trauma, and wrist can be fractured as well. Distal fragments can rotate, and once this rotates, can this damage the leonate as well as the scaphoid mechanism as well. Most commonly, if this happens, it usually requires an open reduction and tunnel fixation of the capitate. Coming to the leonate can get fractured. This can get dislocated, or the leonate could stay there and whole of the carpus gets dislocated. That is when we call it either it's a leonate dislocation or a paraleonate dislocation. But leonates can simply get fractured as well. And that's usually, although very rare, but it happens usually calling a hyperextension injury to the wrist joint with or compression. This is once the avian develops, the avascular necrosis of the lunar develops. This is called as skin box disease, and there is why, because there is scaphoid ligamentous disruption, which can eventually lead to a lot of instability at the wrist joint. Undisplaced fracture are usually immobilized in the cast for 6 weeks. Displaced fractures are reduced and fixed with a screw, and most commonly usually Herbert screw or headless screws are used. In this section, we have briefly gone through what are the other bones which could be damaged as well. The most commonly it is always the scaphoid, but in the proximal row there could be associated lunar fracture as well, although it's very rare. If it's usually the most common treatment is if it's undisplaced, we can treat it in a cast. If it's displaced, we can treat it with the open reduction and internal fixation as well. But more commonly associated with the lunate is the lunate or pallilunate dislocation. In the second row, there are other bones as well, such as trapezium and trapezoid, as well as the capitate. Usually they are not injured, but they can be injured in the force in severe case of trauma or when the first metacarpal gets jammed into the body of the trapezium. Most commonly, they're treated with open reduction internal fixation or with screws or K-bias. Then comes the hamate. Hamate is a bone which is lying on the ulnar side, and the second row is, and the most commonly gets injured when, especially during the golfers are playing the shot. There's a direct trauma to the this is called as the hook of the hamate. That is why it's important, because there is an artery going just passing through that, which can get damaged as well and may lead to AVN of the hook of the hamate. If AVN has occurred, we can simply excise the fragment, but if this is a small fragment, we can also excise it. Otherwise, if a large fragment associated with the fractures of the body, probably we need to go for open reduction internal fixation of this bone. Thank you very much. Keep watching sqadia.com.